Welcome everybody to the meningioma patient support group. Tonight we're going to have a panel discussion, and I do this from time to time. I think the last one we had for the meningioma support group was about 2 years ago. And for this discussion, what I'm going to do is present to our two panelists, Dr. Meola and Dr. Ahmad, a series of cases, of meningioma cases. They've not seen these cases before, and I'm going to ask them to give us their thought process as they work through the cases. Some of the cases, there's more than one one treatment option, so we'll see how they kind of come up to their final recommendation for each of these cases. And then after we get through the cases, V, who's moderating this, will spend about 10 or 15 minutes with the patients, largely going over some logistics, but also to discuss topics for some future meningioma support group meetings. Okay, so Dr. Ahmad and Meola, you ready? Yeah. Okay, so this case is a 54-year-old woman. She presents with some mild frontal headaches, but no other symptoms, and her neurologic exam is normal. So I guess, Dr. Ahmad, in terms of this history, the patient's neurologically normal. Is this something that you would be concerned enough to get an MRI scan on, or when does someone with headaches warrant an MRI scan?
I think it depends on how long the headaches have been going on for, so the chronicity of headaches, and also whether it's impacting the quality of life.
Okay, so if these headaches have been only going on for a week, you would treat it differently than if they've been going on for 6 months.
That's right, yeah. So
Okay.
Something that's been going on for longer will warrant a closer investigation.
Okay, so let's say she's had 9 months of these headaches and they're getting worse.
Yeah, that would be something that would warrant both like a clinical exam and a radiological examination, like a CT and an MR.
Okay, so her neurologic exam is normal, and you get an MRI scan. So why don't you tell me what you see on this scan, and what you might want to recommend in terms of next steps?
Yeah, so this is an MR examination of the brain, and it's a cross section through the midline. There is contrast, and right in the center there is the sella, and also where you're pointing right now, and so a large homogeneously enhancing tumor, which is most likely a tumor which is coming from a bony cavity, which is a sella where the pituitary gland usually sits, and right above the pituitary gland you have the optic nerves as well. So this is probably just eyeballing a couple of centimeters across. So the two areas that we'd be concerned about is the pituitary gland itself, and also the optic nerves which sit above it. So the next steps would be to see what her vision and visual fields are like, and whether there are any cuts in the fields, and also to see what the pituitary gland function is like with a pituitary panel, which is a series of blood tests.
Okay, so just to point out for the audience, so the pituitary gland sits kind of in this area, and Dr. Ahmad correctly pointed out that this tumor, presumably a meningioma, is pushing on the pituitary gland down here. The vision nerves tend to be pushed superiorly, so they would be on the upper edge of the tumor here, and if the vision nerves are under enough pressure, then they can have some dysfunction. So let's say you check the patient's hormone levels and they're normal, but on the patient's visual exam, the patient does have some peripheral vision loss, meaning difficulty, looking to the far sides in their visual field. So what would your next step be?
Yeah, so at this point, we have to have a conversation with the patient as to what management options we have. So this is a tumor that is most likely a benign tumor. It's been there for a number of years and has gotten gradually bigger, and is because it's gradually bigger that the pituitary gland is probably able to compensate from that perspective. I'm concerned that the vision is impacted, and that's because of the tumor pressing up on the optic nerves and the optic chiasm. So this would make me less inclined to follow from a radiological surveillance perspective and consider treatment would be important, because vision is very, very important to maintain. So at this point, the main discussion that I would be having is about surgical resection and decreasing the amount of pressure and the impact that the tumor is having on the optic nerves and the optic chiasm.
Okay, so you said you don't favor observation because of the vision loss, and you don't want that to get worse. But in terms of treatment, radiation, is that an option here?
Yeah, radiation can be an option in two circumstances. It can be done after the surgery as well, to the surgical resection bed of the where the tumor was, and then the other option is also radiation as an option as well, just in view of the pressure effect that the tumor is having on the optic nerves. I would be a little bit more inclined for surgical debulking or resection, and then we could follow that on with radiation such as CyberKnife. But CyberKnife itself, as a preliminary first option, can also be discussed.
Okay, Dr. Meola, your thoughts on this case?
I totally agree. I believe that surgery should be option number one. I wouldn't recommend stereotactic radiosurgery unless unless there are like comorbidities that are too important, too relevant for choosing surgery. Otherwise, I would go for surgery.
Okay, so this presumed meningioma is kind of toward the center of the brain. So what will your approach be to this?
Mine?
Yes.
Well, here there are two potential approaches. So one approach is endoscopic endonasal approach. So going from below, I see that the patient has a very well pneumatized sphenoid sinus, which is the black area immediately below the, immediately below the sella. And the other option is an open resection, meaning like a subfrontal approach. Sorry, I don't have images to show, but anyway, with the subfrontal approach, we can reach the tumor from the lateral side.
So Dr. Meola's, so here's a tumor here, and essentially everything up to the tumor through the nose is all air spaces. So if we look at kind of this model here, here's the opening of the nose. This is all air all the way up to where the tumor is sitting here. So what Dr. Meola is correctly pointing out is that you can use endoscope, and here's a camera. This is an endoscopic camera, and through the nose, you can have access to the base of the skull, and you can remove this meningioma just with a camera system through the nose, rather than making an incision in the head or cutting an opening in the skull. This approach can be used only for midline tumors that are accessible through this nasal approach. So many meningiomas cannot be removed this way, but this is certainly one that has this as an option. Okay, I'm going to go on to the next case. 49-year-old woman, she presents with some dizziness. Her neurologic exam is normal. And so, Dr. Meola, this goes to you. Same question that I asked Dr. Ahmad for the first case. At what point of a dizziness workup do you consider getting an MRI scan versus, other types of workup?
Well, the kind of consideration we can make are really similar to the other case. So again, it depends how severe is the dizziness, for how long the patient has the dizziness, if other specialists were seen by the patient. These are all aspects that I would consider. If the patient has, for example, severe dizziness going on for, let's say, more than 1 month, I could consider doing some imaging on the patient.
Okay, so if the patient had dizziness for a week, you wouldn't image, but if it's been going on for, let's say, 3 or 4 months, you would.
Yes, yes.
Okay, okay, fair enough. So you again, the neurologic exam is normal. She's otherwise a healthy woman, and so
yeah, I see that.
I put my big arrow there.
Yeah, so there is no question. Yeah, I see this a small homogeneous enhancing mass on the left side of the head in the temporal region.
Okay, so
yeah.
How big would you estimate this to be in terms of millimeters?
Maybe 1.5 centimeters,
Okay.
2 centimeters.
So yeah, it looks pretty small. I would guess even maybe even a little bit even under a centimeter. So it's not very large. So I guess here's the question. This was the only finding that was abnormal on this patient's MRI scan. The rest of the MRI, including the workup down by the ears and the balance center of the brain, was all normal in terms of the MRI imaging. So the patient wants to know if this is the cause of the dizziness.
I don't believe this is the cause of the dizziness.
So you think it was an incidental finding?
I do.
Okay. So given that, what's your recommendation to this patient? She's 49, normal neurologic exam, good health, but just has a dizziness. So what would you counsel her in terms of the options?
Well, for this tumor, considering that this is a small tumor, there are no signs of infiltration of the surrounding brain. There is no significant swelling of the brain around this tumor. I can assume that this is a benign meningioma, so meaning histologically benign. So I would recommend the patient to do observation with another MRI in 6 months, and then continue. And assuming that the MRI is stable, then we can follow the patient every year with an MRI. And in case the tumor grows, then we can talk about treatment options. The strategy number 2 is that if the patient feels that, wants something to be done, in my opinion, in a case like this, I would recommend stereotactic radiosurgery. Option number 3 would be surgery.
Okay, but which one are you favoring?
Option number 1.
Okay,
I gave them in the order of priority.
Okay, okay. So she, Dr. Ahmad, she's 49 years old and she's a female and she's in the kind of the perimenopausal period. Her OB/GYN doctor wants to consider placing her on hormone replacement therapy. And she's asking about any potential interactions with that and her meningioma.
Yeah, so there is an association of meningiomas and females and female gender, and we see that there is a higher prevalence of or incidence of meningiomas seen in women, especially of perimenopausal age group, and that is considered to be because of certain receptors which are on meningiomas, which make them more likely to grow in the presence of certain female hormones. So I think in view of that and in view of what Antonio was saying, the surveillance certainly should be, so it won't be a barrier itself from her being on hormonal replacement therapy, but the surveillance should be continued and regular, perhaps rather than annually. We do it every 6 months, do it as in the MR every 6 months, and with a consideration that depending on how the patient feels of getting CyberKnife or the consideration of CyberKnife treatment, depending on how she feels about this meningioma there.
Okay. So another question, because we've been talking about doing surveillance MRI scans on this patient. So that means you're getting MRI scan after MRI scan after MRI scan. This picture I'm showing you is the MRI scan with contrast. So it shows the tumor lighting up. So how would you counsel a patient if they ask you about whether or not they need to have contrast with these scans?
They do need to have, ideally do need to have not only just contrast, but a series of other sequences that we also do, depending on where the brain tumor is in the brain. There are various sequences that we have to do. So for meningiomas, one of the hallmarks of meningiomas is how they light up in response to the gadolinium dye, which is injected intravenously. So unless there is a clear-cut reason not to, or being unable to get the gadolinium contrast, in most cases, it would be recommended to have MR with contrast.
Okay. And Dr. Meola, last quick question for you. The patient has 3 children, wants to know if this is genetic.
Usually it is not genetic in the vast majority of the cases. And again, as Dr. Ahmad was saying, females have a predisposition for this, for meningiomas, and this is related to the hormones. Usually this is not genetic, almost never. Certainly, I would consider if the patient has multiple meningiomas or a combination of meningiomas, vestibular schwannomas, neurofibromas, then I would be more concerned.
Okay, but what percentage of patients with meningiomas have the genetic version versus the non-genetic version?
I would say less than 1%.
Okay, so less than 1% of patients with meningiomas have genetic. Okay, so let's go to the next case. I guess this goes back to Dr. Ahmad. So he's a 68-year-old guy, and he presents with occasional headaches. They're not really bothersome to him, but he basically comes in finally because he's getting some numbness on the right side of his face. So to make it easier for the patients in this meeting, I put some circles around the area in question. But tell us what you see, Dr. Ahmad, and tell us whether or not this explains the patient's symptoms. And then lastly, give me some of your recommendations.
Yeah. Okay, so what we're seeing is in the circle, right in the middle of the circle, there's a black area, and that's the internal carotid artery. And around right there, and around it, you can see a lighter white or grayish area, almost like in the shape of a triangle. And that's the meningioma, which is kind of encasing and enclosing the artery. And around the artery run nerves which supply the face and the eyes. And one of them is the nerve that supplies the sensation to the face. And so that certainly does merit the marrying up of the clinical and the radiological picture. That certainly does, it coincides.
Okay.
And right, and then in terms of, so these, so the next thing is just to make sure with a clinical examination, a neurological examination, just make sure that the eyes, that there's no double vision, because that's also another nerve that goes through that area where the meningioma is. And if the only symptoms or presenting symptom is of right facial numbness and there's no vision and vision issues involved, then we come back down to primarily two options. One can be, which I would be a little less enthusiastic about, would be to follow up from a radiological surveillance perspective. The second would be to consider cyberknife or stereotactic radiosurgery to this area, and this is an area that traditionally, from a surgical approach, we are a little hesitant, only because of the proximity of the nerves to the carotid artery, which would make us a little less inclined to take the surgical route. It is possible, it can be done, but in terms of impeding the growth of the meningioma, my recommendation would be to consider stereotactic radiosurgery to this.
Okay, so his vision is good. He doesn't have any vision compromise, and his facial numbness is mild. I think, and he's 68. So I guess you mentioned a couple different options. So at the end of the day, would you recommend observation or treatment with the radiosurgery?
Treatment with the radiosurgery.
Okay, and then what would you counsel him in terms of what's the chance the headaches are going to get better? What's the chance the facial numbness will get better?
Right. So the facial numbness may, so the aim, it would be just important to just discuss what the aim would be for this meningioma to stop it from getting any bigger and not to continue having the effects of ongoing or increasing compression. So the facial numbness may stay the same, with an improvement after 18 months or so, 12 to 18 months. So that's not going to be a rapid fix from the numbness perspective. And the headaches may or may not be because of this particular meningioma, but that again, once the tumor starts stabilizing in terms of growth and then hopefully decreasing in size and volume, then there may be an improvement. But the whole aim of considering stereotactic radiosurgery would be for the meningioma not to continue to increase and then potentially involve any of the eye nerves.
Okay, Dr. Meola, a quick question for you. So this patient and this, that has these set of films right now, is 68 years old. Would your recommendations, Dr. Ahmad recommended the radiosurgery because of the facial numbness. She's trying to prevent the patient from developing any worsening symptoms. Let's say the patient was 88 years old, but exact same symptoms and exact same scan. Does that change how you would manage this and what you would recommend?
I would still recommend stereotactic radiosurgery.
Okay.
As first option.
Okay.
I could be a little bit more hesitant to recommend surgery, maybe, but certainly the fact that the patient is 68 or 88 does not change the risk of potential adverse effects of stereotactic radiosurgery, and usually stereotactic radiosurgery is really very well tolerated in patients above 80-year-old.
Okay. So next case, I think this goes to Dr. Meola. Okay, so 65-year-old female with she's been in the US only about 6 months. She's had some progressive difficulty walking. Previously, she lived in the Middle East, so we don't have too much in terms of prior records. So she now resides in the United States. She comes to see you with an MRI scan, which I'll show you. Her neurologic exam shows that she's kind of diffusely weak in all in all her arms and legs. She wants to kind of know what you see in the scan, whether it explains your symptoms and what you would recommend. Okay?
Sure. All right. This is a Clive Meningioma. This is a meningioma that is essentially on the posterior surface of what we call clivus, I don't want to go into much detail. Anyway, that is the bony part that we have immediately behind our nasal cavity. And so there are the nasal cavities, and then behind that there is the clivus, and behind the clivus there is this meningioma. So the meningioma is compressing the lower part of the brain and is deforming the lower part of the brain. The name of this part is brainstem. In the anterior part of the brainstem, there are the fibers that serve the motor function for all the extremities. So basically, the radiological picture is consistent with the clinical picture.
Okay, so she's 65. She's kind of just weak all over the place in both arms and both legs. And so you think the tumor explains that?
There is also, I don't know if this is a cat, maybe I see the frontal area is,
This is just,
I should see,
this is just midline artifact.
Just midline, okay,
yeah,
because sometimes we have the fogs, in the midline, so we have that artifact. Yeah, I think this could explain the findings. Yeah.
Okay. So which management option would you choose here?
How old is she? Sorry.
She's 65.
65.
She wants to know if she can follow this.
No, I would do something for her.
Okay, she wants to know if she can have radiation then.
Well, since she's symptomatic for this tumor, and the tumor is already large, I would advise her to do surgery as first option. Option number 2 could be stereotactic radiosurgery.
Okay, so the point here what Dr. Meola is trying to say is that, so here's the tumor right here, this white area. This is the clivus bone, this second white structure next to the tumor. And neurosurgeons are not very creative. We just name meningiomas off the bone that they grow off of. So a tumor that grows off the clivus bone is called a Clivo Meningioma. And it's compressing the brainstem, which is a circular kind of round structure that connects the brain and the spinal cord. And all the functions, all the nerves that go to the arms and legs pass through the brainstem as it goes down the spine here. So something like this can easily compress the, what Dr. Meola correctly identified as the motor tracts, the nerves that go to the muscles of the arms and legs, and then that can cause weakness. So usually in this situation, because the patient is developing weakness, we do typically treat these surgically because the goal is to decompress the brainstem. Otherwise, the patient runs the risk of progressive worsening in their weakness. And as patients get weaker and weaker, what we start to see is a series of falls. Patients start losing their balance and start falling. And once they start falling, then you open up a whole new level of potential injuries, such as, injuries to the head, bleeding, from some sort of trauma, fractured hips, things like that. So we really worry about ability to ambulate and stand in this situation. Okay, so this is a little cartoon. So here's the clivus bone is right here. So here a meningioma kind of sticking by the clivus bone is called a Clivo Meningioma, and you can see how it compresses the brainstem. And again, neurosurgeons just name meningiomas where they grow from. So the foramen magnum is a bony opening in the skull. So if you have a tumor down here where the base of the skull opens, that's a foramen magnum meningioma. The olfactory groove is up here. This is where the smell nerves come. That's what olfaction is, smell. And so if you have a meningioma in this location, it's called an olfactory groove meningioma. So you'll see that these meningiomas all tend to grow off structures by the lining of the skull. So even up here, they grow from the lining of the skull. Okay. I think I can't remember who's up next. Is it Dr. Ahmad or is it? No, I gave that one last one to you. So it's just no, it is Dr. Ahmad. It's your turn, I think, right?
Okay, yeah.
Okay. 54-year-old woman, and basically she comes in with a scan that was obtained after she was in a car accident. She wasn't having any problems either before or kind of after the car accident, but because some ER physician was worried about some trauma that she might have sustained during the accident, they obtained this scan. And by the time she sees you in clinic, she says she's pretty much back to normal, no sequelae from the car accident. Her neurologic exam is normal, and this is her scan.
Yeah, so what we're seeing here on the left-hand side is a posterior fossa. So that's the hindbrain of the patient. So this looks probably a couple of centimeters across, maybe 2 centimeters. And it's close to what we call the cerebellopontine angle. And I'm looking overall at the effect of this tumor, which is kind of knuckling into the cerebellum, which is part of the hindbrain. And there doesn't appear to be a lot of swelling, and the structures which are supposed to be in the midline where the CSF is in the middle. So again, because meningiomas are slow growing, the body has adapted, and there isn't a large impact on the brain where this meningioma is.
Okay, so so she's, like I said, completely normal. She's 54. This is about, maybe let's say this is about 1.5 centimeters, maybe a little bit bigger. Okay. So 3/4 of an inch in diameter. What would you recommend for her in this situation?
Yeah, so again, we can put the options on the table and discuss about whether she wants to continue reviewing this from a radiological surveillance perspective. But in terms of the size, if it is 3/4 of an inch, this is the kind of size which right now isn't causing any issues, but she's 54, she's going to live another, 3 decades. This will inevitably grow bigger. And even though it's a slow process with meningiomas, they don't rapidly get bigger. This is going to be a slow process, but over 3 decades, we do expect this to get to a larger size, which may then start causing problems. So in anticipation of that, it would probably be a good option to start considering or start having the discussion about stereotactic radiosurgery to this sooner, while it's a smallish size, or the size that it's at. Okay,
so sounds like the option you're favoring is consider getting it treated now with radiation before it becomes a bigger problem down the line.
Correct.
Okay. Right. At what size would it be too big for radiation, or where would you recommending the radiosurgery now, but when would you change that, or what would make you think about changing that recommendation to surgery?
Right, when it's about, we use it like about 3 centimeters, 3.5, when it becomes that kind of size, that's when we get a little bit it kind of turns the scales more towards surgery. So this kind of size is probably more appropriate for CyberKnife and or stereotactic radiosurgery.
Okay, so at this size, radiosurgery sounds like it's a great option. But if this patient were to wait and it were to grow, then depending on the size, you might change your recommendation to surgery. Is that correct?
Correct.
Okay.
Correct. And also the bigger. Go ahead.
Go ahead.
No, I was going to say the bigger it gets, then they're going to be more neurological deficits likely to occur. And when in the presence of neurological deficits, then surgery becomes more likely or first option in the queue.
Okay, so I think what Dr. Ahmad's saying is that the patient certainly has the options to watch this or treat it with radiation or treat it with surgery. Right now, the patient's not symptomatic, so either watching it or treating it with radiation, an outpatient, non-invasive radiation treatment seems attractive. But she does correctly point out one of the downsides of not treating it and just watching it is that if the tumor either grows larger or if the patient develops some symptoms related to the tumor, then we as neurosurgeons may change the recommendation or the number one recommendation to that of surgery rather than radiation. And just to get some clarification, Dr. Ahmad, if the tumor is bigger and it's causing symptoms, why would radiation not necessarily alleviate the symptoms?
So surgery is more of has an immediate effect on reducing the effect on the surrounding tissue. So it's a debulking, you're reducing the actual amount of the tumor, which is occurring during the surgery. CyberKnife or stereotactic radiosurgery will have that same impact, but will take a longer time because it takes longer for CyberKnife to work, which will be over months. So that's the reason. So if there's a neurological deficit and the patient is unable to do something because of the symptoms of this brain tumor, then the fastest way to alleviate that would be by surgery.
Okay, Dr. Meola, comments?
No, not really. I don't have comments. I agree on everything. From my standpoint, I usually do not have cutoff size for deciding the stereotactic radiosurgery versus surgery. We can treat with radiosurgery potentially, tumors of any size. The problem is that when we have tumors in that region, which is known as the posterior fossa, the problem is the compression of the brainstem, and so when I see some compression, some deformation of the brainstem, I would prefer surgery over stereotactic radiosurgery. And certainly, the problem with the size is that it is different if we have, like a 2 centimeters tumor in a small posterior fossa with respect to having the same tumor in a patient with a larger posterior fossa. So certainly the size is important, but we have also to consider, what is the size of the other components of the head. Yeah,
okay, let me just ask you, let me put a little spin on this. So same patient, same scan, but instead of symptoms, she's having pretty severe headaches. Does that change how you would manage this?
Well, it depends. For example, the headaches could could be due to the fact that the patient has, for example, a hydrocephalus, which can be related to the fact that maybe she has a compression on the fourth ventricle. Then, if she has a situation like that, certainly I would consider surgery.
Okay, but let's say it's this exact scan. So there's no pressure on the brain, but she's having pretty bad headaches.
Well, the headaches could or could not be related to the tumor.
So what would you tell
probably
people?
I would do stereotactic radiosurgery probably. You know, for a tumor of this size, I mean, with this scan, I would do stereotactic radiosurgery.
What if the tumor was causing the headaches? What's the chance that the stereotactic radiosurgery or the CyberKnife would alleviate the headaches?
Well, if the tumor shrinks progressively, the headaches are going to get better. There is also a chance that the tumor suddenly swells up, and the chance is less than 5%. And then the patient could have even more severe headaches and could have also other symptoms.
Okay, I think
certainly if we don't want to take any risk of headaches, we can do surgery.
So I present the headache. I present the headache question because it comes up not infrequently that a patient with a meningioma is found and their only symptom is headaches. And you know, headaches are very generic, non-specific symptoms. Oftentimes, the patient with a meningioma and just headaches, the headaches don't even seem to be localized to the part of the skull where the tumor is located. But I do think that if you have headaches and we think the headaches might be related to the tumor, that surgery does potentially give you a little bit higher chance than the radiation to alleviate the headaches, because it may be a pressure phenomenon and radiation kills the tumor, but usually kills it at the current size and not necessarily shrinking it. It may just die at that size. And so if it's a size of the tumor, somehow it's causing headache, either from pressure on the brain or irritation from the inner lining of the skull, then surgery might give you a better chance of headache relief. And so that's kind of generally the philosophy I have with headaches and meningiomas, is that the kind of the more severe the headaches, the more likely the pendulum is going to shift towards surgery. You know, because the radiation, you know, because it doesn't necessarily dramatically change the size of the tumor, it just stops it from growing, may not change the headaches. Let's see. Okay, the last case, and then we'll open it up to questions and answers. And there's some questions that are starting to come in. I will make sure we get all the questions answered, but I want to make sure that we get through this last case. And I think for the question and answer, I think V, who's moderating this, may open it up for direct questions by unmuting the audience. Whose turn was it? Is it Dr. Meola's turn?
I guess so.
Okay, you're the lucky one with this case. Okay.
Okay.
So this person's 60 years old. It's a woman. She lives alone. She's kind of lived alone for many, many years. Once every month or so, a neighbor might see her kind of come out to the porch, but otherwise she stays to herself. Doesn't get on public. Gets all her groceries delivered via Instacart. Gets all her other stuff shipped to her via Amazon. So never comes outside. And when she comes outside, she always has a hat on her head. Okay. So one day she comes outside and she's kind of babbling and she's all confused and still got the hat on her head. But the neighbor across the street sees her and she's starting to kind of yell and scream and hallucinate and calls 911. Okay. So she gets taken to the emergency room. And the emergency room, they get a scan on her and they call you to see her. Okay, Dr. Meola?
Right.
Okay. Tell me what you see and how you would manage this.
Wonderful. So this is a giant meningioma of the right, I would say, frontoparietal region, and this has an extracranial extension. So basically, this meningioma goes across the bone, and it goes both on the outer side of the bone and on the inner side, and cause significant brain compression. Yeah, so this is what I see.
Okay, so now we kind of know why she might be wearing a hat, because she's had this bump growing for a while.
Yeah.
So what are we going to do now? I mean, she's now why do you think she's confused?
Well, she could be confused because she has important, severe compression of the brain. She probably could have also some swelling of the brain. So this could be the reason. Mass effect, what we call mass effect.
Okay, so you think it might be brain compression, and
Could
you
be.
talked about the size. So the black area is the bone, and so we see some meningioma on the inside of the bone. We see some meningioma on the outside of the bone. Let me ask you this, Dr. Meola. Why is this bone, this black? Why is it so thick here where the meningioma is?
Because we can have some what we call hyperostosis, which means that the bone becomes thicker, it is invaded by the meningioma and is more vascularized and tend to become thicker, and at the same time, in some areas, it can be also broken and even more fragile. So it is a rearranged area of bone.
Okay, so what's your recommendation for this patient?
Well, this patient probably needs surgery. The only question I have is whether or not this patient needs also like a preoperative embolization of this tumor through an endovascular approach in such a way that we can reduce the vascularization of this tumor. And this so I would discuss this case also with a radiology to figure out how hypervascular is this tumor. But assuming that we want to do surgery, I would go for surgery. So this means that we will need to remove both the extracranial and intracranial component. One of the issues that I see here is I'm not sure if the superior sagittal sinus is invaded by the tumor or not, because this is also another important aspect to consider.
Okay, let me just hang on a second, Dr. Meola. So I just want to point out a couple of things to the audience. So Dr. Meola is basically showing that this is the MRI scan with contrast dye, and we can see the meningioma is brighter than the surrounding brain because it's taking up some of the contrast dye. And that tells us that the tumor has a blood supply to it and can be vascular. Sometimes these tumors can have a very, very rich blood supply and have a lot of blood flowing through them. So when Dr. Meola talks about embolization, he's essentially talking about a procedure where the radiologists can, prior to a surgery, inject some glue through the blood vessels of the tumor that will block the blood flow through the tumor and therefore make the surgery easier to do because the tumor has less of a blood supply to it. So that's something we often consider for larger tumors. The other area that he correctly pointed out to is this area right here. There's a structure called the sagittal sinus. It's the primary large vein that drains the blood from the brain back to the heart. And it's a structure that tumors like meningiomas can grow into or compress. And if the tumor grows into or compresses the sagittal sinus, then it makes it a much trickier operation, because the sagittal sinus is a structure that normally if there's blood flow going through it, it's not a structure that you really want to injure or sacrifice somehow during the surgery. However, sometimes over time, the meningiomas can grow into and completely occlude the sagittal sinus. And in this case, it looks like the tumor's at least getting into the sagittal sinus. And if the sinus is already blocked off, if this venous drainage system is already blocked off by the tumor, then you can go into the venous sinus and remove the tumor. So it's very important to assess that prior to surgery, whether or not the sinus is involved. Okay, so Dr. Meola, you're recommending surgery. Dr. Ahmad, any thoughts of yours on this?
Yeah, no, I think I'm in agreement. So there is no doubt that this is a large meningioma that starts from the midline and then goes further down. We can see the dural tail, which is part of the meningioma, kind of shoot down a little bit. So there will be concerns from the point of view of getting a resection to reduce the burden on or the impact on the rest of the brain. And then also in terms of closure, it might be something that we might have to talk to our plastic surgery colleagues to make sure that there is healthy skin, to make sure that there will be viable skin closure from that perspective and good wound healing. And also because all of that bone will be removed, which has all the tumor in there. There will be some form of a cranioplasty, which is a synthetic bone replacement where the at the point of at the skull. So we'll be taking out the native bone, which has all the tumor in there, and then putting in synthetic bone or a combination of synthetic bone and a mesh, a titanium mesh, to basically reproduce the skull on that side. Okay.
Let me see. So I think I'm gonna open it up to questions now. So V, you feel free to unmute the audience.
For the audience, the way the webinar is set up is that I cannot unmute all. So if the attendee patients, you can raise your hand and I can go ahead and just unmute you. If you have
questions, there's two ways you can submit it. Once on the screen, there's a QA panel that you click on, allow you to type in your questions. The other option, as V said, is you can raise your hand and we can individually unmute people. So I'll start with the questions that were typed in so far. So the first question is a question about the terminology here. And so different terms were being used. They all sound the same. So cyberknife, stereotactic radiosurgery, radiation, are they the same or different treatments? So they're basically terms that are used interchangeably. The generic name is stereotactic radiosurgery. That's the generic name for focused radiation. The machines like a cyberknife or a gamma knife, those are all trade names for machines that deliver stereotactic radiosurgery. So as physicians, we tend to bounce in and out and use the names interchangeably, but they're essentially all the same. Another question came in. The meningioma my meningioma is at the CP angle on the right side. I went through radiation treatment in 2015. The tumor stopped growing. Now, occasionally I see some migraine patterns with my right eye. Do I need to look further into this problem? So based upon the location of this tumor in the right, what's called the cerebellopontine angle, this should not be causing any kind of pattern changes in your eye. The vision nerve that controls like the actual seeing of light shapes and things like that would be too far away from your tumor to be the cause of this problems. So you mentioned that this is, you call this vision changes migraine pattern changes. So it's possible that what you're seeing is related to some sort of migraines. Not all migraine variants involve a headache. You can get vision changes and shapes in your eyes without the headache. So that's possibly that's the case. But based upon the limited information that I have right now, I would say it's not likely that this is the cause of the vision changes. Okay, other questions that I can answer at this point? Okay, another question just came in. Question regarding regrowth of a meningioma. Can a resected tumor with some remains, I presume that means some residual tumor, stay stable for several years and then regrow? I'm 5 years from surgery with no regrowth, but I'm worried that the tumor might want revenge on me like a horror movie. Okay, so Dr. Ahmad, you want to answer that question? Surgery with some residual, no growth in 5 years.
Yeah, I think that's the whole rationale of why we undertake ongoing radiological surveillance after the surgery. So the likelihood is, if that things have remained stable, they may remain stable. But the reason why there's going to be surveillance and interval scans even after the surgery is to make sure that there is no regrowth. And with every scan that you have, it's compared to the previous ones to make sure that there really is no regrowth from that perspective. But I would want to just allay your fears a little bit that it's not, these aren't rapidly growing tumors, and so I don't think you should worry about it, that there would be a rapid expanse and there would be an issue, because if they're that's just not the type of tumor that meningiomas are. So if I can allay your fears from that perspective, and that's really our rationale behind the whole radiological surveillance, is to make sure that there isn't any increase in the size of the residual, which is already there.
Okay. Let's see, there's, I think that's, V, did you have any questions else that came in?
No other questions.
Okay, well, great. I want to thank everybody for attending and the attention tonight. And thank you for Dr. Ahmad and Dr. Meola for your time. So V, I'll turn it over to you for the last few minutes, okay?
Okay, thank you, Dr. Ahmad, Dr. Chang, Dr. Meola.
Right. Thank you. Bye.
Good night. Thank you.